Okay, welcome everyone to the session on germline predisposition. My name is Marcin Wlodarski and I'm from St. Jude Children's Research Hospital in Memphis, USA. And I co-chair this session with Professor Junko Takita from Department of Pediatrics, Kyoto University. Today we will have three talks, one on DDX41 syndrome, second on GATA2 and SAMD99L genetic predisposition, and third on JMML. And we are happy to have both adult and pediatric representation in this session. I will start with introducing Dr. Carmelo Gurnari, who has double affiliation at the Tor Vergata University in Rome and the Cleveland Clinic USA, and his talk is on DDX41.
Hello, everybody. Thank you, Marcin, for the kind introduction, and thank you to the organizing committee for the invitation. It's my first time in Japan, so I'm very happy to be here and enjoy this meeting and also Japan. Today, my job is walk you through DDX41, and we see from the program that we are doing backwards. We start with late onset disease and we go then to the more pediatric disorders. These are my disclosures. So we all know that in the last decades, a growing body of evidence has shed light on germline predisposition trait in myeloid neoplasia. A lot of genes have been discovered in the last 2 decades, and with the advent of NGS, we also screen myeloid neoplasia cohorts for the presence of these inherited traits that have been found in up to 5–10% of MDS and AML cohorts, with some having specific clinical and genomic characteristics. But why is it important to understand if the patient that we have in front of us has a germline predisposition trait? Because some have specific clinical features, in order to avoid inappropriate treatment or consider tailored approaches. And then also because when we talk about germline predisposition, as the word is self-explanatory, we also have to take into account the family. So patients have relatives who may carry the same germline trait. So we have to always take into account these, in particular, when we talk about myelodysplastic syndrome, for the only curative approach that we can propose to this patient, which is bone marrow transplant. And we, together with the EBMT and a lot of people that are present today here, provided some guidance on this specific instance in a recent Lancet Hematology publication. Let's talk about DDX41 in particular. DDX41 is the master of many. It's been described as important in numerous cellular functions, starting from the innate immune sensing, the STING pathway, the R-loop regulation, the splicing, and in particular the RNA processing. And DDX41 broke a little bit this dogma of pediatric population as the only one to be screened for inherited traits. And this is very evident from the lower right side of the slide, where you can see that DDX41 has a late onset. So this patient with myelodysplastic syndrome and AML, whose genomic underpinnings are DDX41 mutation, usually present at later stage in life, usually 6th, 7th decade of life, especially when we compare to other genes. In a seminal publication with Dr. Makishima and Professor Ogawa, we described the topography of these variants, DDX41, as a very peculiar way of provoking myelodysplastic syndrome that entails the acquisition of a second somatic and contralateral a mutation, usually in the 525 codon, which impacts on the helicase activity. And this double configuration, germline plus somatic, accounts for up to 60% of DDX41 mutant MDS. The remaining are 30% only germline and about 10% only somatic. On the right, you see a cartography of DDX41 mutation. And this is because, according to the genetic and ethnic background, we see that there are some specific germline traits that are more enriched in Asian population or Caucasian population in particular. What are the other features that identify DDX41 as a unique subtype of myeloid neoplasm? As I said, is important to know because it accounts for up to 80% of the known etiologic fraction of germline predisposition traits in myeloid neoplasm. There's a gender imbalance with a male bias. And as you can see from the lower left cumulative incidence curve, the risk to develop myelodysplastic syndrome or AML is almost negligible up to the age of 40, while it increases rapidly after that age to have, let's say, a 50% lifelong risk. As you can see, the penetrance is incomplete when we compare to, for instance, SAM-D9 or SAM-D9L, as we will see later on. But what we know about the general population, because our work focuses on the relative risk of the relatives of the family affected. In some more insights on the cognate risk has been shed thanks to this work on the UK Biobank, leveraging almost 500,000 exomes, and the author found germline variants in up to 1 in 129 people, but when restricting to only pathogenic variants, this was 1 in 429. What was important is that carriers did not show any CBC abnormalities before the development of MDS or AML. There was no increase in clonal hematopoiesis, which was instead increased in cases that were not related to DDX41 mutation, and there was a difference in the odds ratio for patients carrying truncating start loss or missense mutation. The absolute risk of myeloid neoplasia in this population was overall low, so 3.21%, with always a male imbalance. We have also an issue when we talk about DDX41, because we know we get so many referrals now that NGS is so widely used, and we had also some observation by which a patient with so-called VUS in DDX41, according to ACMG criteria, were found to have similar phenotypes, similar clinical characteristics, similar response to treatment than patients with DDX41 pathogenic. So the group of Professor Afferlach from MLL laboratory applied a Bayesian framework for the integration of somatic DDX41, so this germline plus somatic constellation, into pathogenicity assessment, and this was able to upcode previously VUS according to the ACMG criteria. Disease phenotype and prognosis of DDX41 mutant MN are very peculiar. In particular, patients present with high-risk MDS, excess blast type 1 or 2, and secondary AML, what probably it was called oligoblastic AML, so in between 20–30% blast. Leukemic evolution is particularly faster in patients with truncating mutation, and survival outcome seems to be better when compared to wild-type cases. However, no commutation in common myeloid drivers seems to impact on overall survival, and this holds true even for TP53 with biallelic inactivation. So 2022 introduces like a dilemma with DDX41 in the MDS and also in the AML world. I will focus on the MDS part for the purpose of this presentation. Because DDX41, we have heard it yesterday, is not accounted for in the IPSSM, and this was because while it predicts a better overall survival, it also has a shorter AML-free survival. So the current prognostic schemes fail to capture the invariant features that the DDX41 mutation imprint to MDS. So we collected international collaboration, thanks to the collaboration with Kyoto University, MD Anderson, London colleagues, Rome, and Cleveland Clinic. And we gathered more than 400 cases of patients with MDS or AML with myelodysplastic, with the DDX41 mutation. We first applied to the MDS cohort IPSS-R and M, and you can see that while in the wild-type counterparts, you see a clear separation of the disease risk categories. This is not the case for DDX41 mutant. Overall, the shift to IPSS-R to M was 51%, so 1 out of 2 patients were up or down stage, and in particular, 38 were up and 62% were down stage. And when we did pairwise comparison in order to understand what was the power also of prognostication in between the disease risk groups, we see that in the heat map, you see that the shades of red mean significance, while for the wild type, both IPSS-R and IPSS-M work very well. This is not the case for the mutant counterpart. We have seen yesterday in the presentation by Elsa Bernard regarding the taxonomy that DDX41 is indeed enriched in excess blast type 2. You see that in the right part of the slide. And also in our cohort, patients with the specific germline plus somatic constellation tended to present with higher risk diseases and higher bone marrow blast. We then tried to identify which were the driver of this shorter AML-free survival. And we identified age, gender, the presence of truncating mutation, and R525 as independent risk factors. And our model was even better than other models accounting for IPSS-R, M, age, and gender, as you can see from the lower right panels showing the C statistics. When we looked at overall survival, the 525 mutation was the only independent predictor impacting on survival. What about treatment? On the left side, you see data from a very recent paper from the French group showing how azacitidine have a higher overall response rate and complete response rate in patients with DDX41 when compared to wild-type counterparts. And this also translates in a better prognosis when looking at overall survival in the curve. In another paper, instead from the Japanese group, it was very intriguing to see how, while these patients that were treated with azacitidine had higher response rate to this treatment, somatic DDX41 mutant clone size did not correlate with the blast ratio or the response to treatment, which instead was the case for TP53 that you can see on the lower part of the slide. A few words on the AML side. Also, in this instance, DDX41 mutant have a better prognosis when treated with intensive chemotherapy. These are data from the AlphaPhilo study, Duployer et al., Blood 2022. And then there's, however, let's say a consistent positive prognostic signal across various treatment and therapies that have been tried in small cohorts, like low-intensity plus or minus venetoclax, HMA venetoclax, lenalidomide, and even low-dose melphalan, as you can see from the slide, mutant are always better, have better outcomes than wild-type counterparts. And now I want to show you this very particular case that happened to me in the clinic. So this is a 69-year-old patient, a male, with MDS, hypocellular bone marrow, trilinear dysplasia, 10.5% blast. He presents with normal karyotype, NGS analysis, which didn't account at that time for DDX41, came out negative. So the patient was at MDS EB2, higher risk according to IPSSR, and was referred to the transplant team because he had a potential donor who was his male sibling, 59-year-old. When we did the CBC to the male sibling, well, what we discovered was a pancytopenia that later on was found to be a myelodysplastic syndrome. This obviously enlightened us, and we did an eureka moment, and we expanded the myeloid gene panel with the known germline predisposition trait, finding the classical germline plus somatic sort of constellation. We confirmed in both siblings the germline trait in non-myeloid DNA, and when we did the same panel to the bone marrow DNA of the brother, what was even more intriguing was to find the same genetic architecture, no additional mutation or cytogenetic lesions in both brothers, but look at the same second somatic event, which was the same for both brothers and was different from the canonical 525. So we're now collaborating with Timothy Clone. You see here a picture of us enjoying a pizza in Rome, and we are now trying to understand what is the impact of this specific second somatic event that is not the canonical and recurrent one and doesn't fall in the helicase domain on the protein function. So what about transplant? We now know that there's a problem with when we identify DDX41. So every effort must be made to avoid selecting a donor that will cause what we define as DDL, so donor-derived leukemia. So the inadvertent transfer of the same genetic trait from the donor to the patient. This has been found later on in cases of donor-derived leukemia that then have been screened in the literature, and DDX41 is among the top hit in these cases. And we know that a normal CBC, we have seen it in the previous papers, is not sufficient to rule out for germline predisposition. So when we find a patient with DDX41 and we want to candidate for transplant, we always have to take into account and segregate the family and the potential donor for the presence of this genetic trait in the pedigree. Also, the identification of this germline variant should prompt activation of unrelated donor search and cascade family genetic counseling, always with the help of a psychiatrist, of a psychologist, or a dedicated team, because we know that this opens a Pandora box in a family. But however, we know that sometimes transplant urgency, legal frameworks, or family refusal for germline testing may be an obstacle, a barrier for optimal transplant counseling. And what about the actual transplant? What do we know for DDX41? We know that patients with DDX41, and perhaps this is related to the fact that DDX41 has impact on the STING pathway and the innate immune system, have a higher rate of severe acute and chronic GVHD. But we also know from this study that the use of post-transplant cyclophosphamide as GVHD prophylaxis abates this higher rate of GVHD. And then I would like to finish with my two passions, DDX41 and UBA1. This is a very particular case where two rare oddities can strike together. 68-year-old male who was a retired fighter pilot with rheumatological symptoms, non-Hodgkin lymphoma, MDS, and among others also had DDX41, canonical methionine 1. and UBA1 canonical methionine 41. So in a prospective study that has been recently published in Lancet Hematology on more than 2,000 patients with cytopenia that were screened at Leeds University, an extended sequencing from a subgroup of patients with sequential samples and no mutation in an initial myeloid panel that did not have these two genes, found that later on, when they retested this patient with an extended panel, the patient that did not show any particular mutation had increased chance to have precisely DDX41 and UBA1. And this is an argument to emphasize and to stress that these two genes must be part of a common myeloid gene panel that we routinely use in our practice. And I want to finish with these take-home messages. We know that DDX41 is a unique disease entity. It opens the Pandora box of germline predisposition, so we must bear in mind to always take into consideration these for clinical practice. Has a late onset with a male bias, patient present with bone marrow hypocellularity, normal karyotype and a low burden of mutation. Let's say DDX41 is self-sufficient, especially in the genomic constellation germline plus somatic. It defies current prognostic schemes, so we are working on building a specific DDX41 prediction model, has generally a favorable prognosis when compared to wild-type counterparts with a good response to treatment, and the only one mutation that has a particular impact on overall survival seems to be the 525H among the DDX41 mutant MDS. And with this, I would like to thank you for the attention, and I would like to take any questions. Thank you.
Okay, thank you very much. Very, very, very important talk. These patients constitute a problem. I have a brief comment and a question. So we manage, as everyone else, to transplant a number of patients with sibling DDX41 mutated bone marrow before it was known. And I could just comment that 2 of these patients actually developed high-grade lymphoma derived from the graft. If that depends on the HSCs that you took over, or if it's something in the body microenvironment promoting lymphoma, but that was just a comment. My question is actually how we do with transplant decisions, because we know that they get more GVHD. We know that they have a slightly better prognosis than the IPS-small score. And I find that one of the most, because we have many of these patients, most difficult decisions when they are approaching between 65, 70, 60 to 70, some comorbidities where you, in a more traditional MDS, would say, yes, if the patient is with me, I can go for a transplant. Here, so how do you do? How do you do when you sit and counsel patients?
So thank you very much. This is like, I think, the elephant in the room, because as I think you pointed out, DDX41, while presenting with higher risk features, have indeed a good prognosis. What I will say is that we always have to take into account in transplant decision making the disease characteristics, and in particular, I think, and we will hopefully be able to demonstrate it soon, the presence of the 525. It's like an important determinant of negative prognostic impact. So when perhaps there's the 525 as second hit, this might be a consideration for like at least identifying a suitable donor. And then perhaps in a relatively young and fit patient who has been failing multiple line of treatment, that's also like something that we will consider for transplant.
So if you have an azacitidine imperfect responder, would you then wait until because, or will you check regularly for P53 mutations, which also is something that appears during?
yeah, thank you. This also like offered me the possibility to expand a little bit. So TP53 mutation in DDX41 are not like so common. What we see, the only signal that we have seen is for CAX1, for instance. So in a perfect responder, I will say I will wait, especially if he or she is on the upper edge and we are like, we don't want to touch the patient and candidate him for transplant.
So perhaps we should have a European little register for those with transplant so we can learn something.
Yeah, absolutely.
We can take 2 more questions, quick questions, please. Thank you.
Can I? Yeah, thank you, Carmelo. Fantastic talk. Yalzan Madanat from UT Southwestern. So you brought music to my ears when you said these mutations need to be on the somatic panels, because a lot of the commercial panels do not have UBA1 or DDX41, so we definitely underdiagnose both of these. And I do call on the Vexus Foundation or the MDS Foundation or patient support groups to really push for the need to have those mutations on the panels. My question to you is more regarding therapy options. Given the great response with intensive chemotherapy, Ven-Aza, or even lenalidomide-Aza, because DDX41 is on chromosome 5, and what about chromosome 5 that makes it sensitive to lenalidomide? But which of these options would you favor in this day and age for patients if they're fit and young, given the very nice responses with Ven-Aza?
So according to the literature, I think that it's always a good option to start with azacitidine and see if the patient responds or not, and we are talking about MDS, right? And then obviously you have always the option to top up with venetoclax at later stages if needed, and also good to rescue the patient with the other approach like low-dose melphalan has been shown, works very nicely, good response rate and median overall survival in patients that like all in all have like a median age at onset of 69, 70. So of course like we're on the upper side of the patient cohorts. So I will say that like then to the transplant, I just like gave my opinion, and for intensive chemotherapy, I've shown like for AML, this works very nicely, and they even have better survival than core binding factor mutation, which means like they have the best outcome of them all.
But in my experience, they all have like 15 to 25% blasts. So whether it's AML or is intensive chemotherapy bad for MDS? I guess that's DDX41 mutated, right, with 18% blasts.
That's something that deserves more study.
Okay, one last good question.
Okay. I'm Motorukato from the University of Tokyo. Thank you for a great talk. If you focus on the donor-derived leukemia with the donor or with DDX14 variant, is there any relationship with the age of donor and the time of onset of donor-derived leukemia?
That's a very nice question. So in the case that are reported, there's no such a relationship. So I cannot answer this question. What I can say, and is particular for DDX41, is that even when we are outside of donor-derived leukemia, patients with DDX41 that have been transplanted tend to relapse even at later stages. So DDX41 is the top mutated gene in very late relapse after bone marrow transplant, so more than 5 years, recapitulating the same exact clonal architecture that they had before transplant.
Thank you.
Okay, thank you very much, and I would like to introduce the next speaker. The next speaker is Dr. Marcin Wlodarski from St. Jude Research Hospital, and his paper is entitled Catatuzumab Genetic Predispositions.
Thank you very much. It's really a great honor to be here and see some friends. Thank you, Dr. Ogawa and the organizing team. I was in Japan at the GSH meeting last year, and I want to thank you for your trust in me to come again to Japan, to invite me again to Japan. So today I will try to show you some new data from my lab. I have no disclosures. and this is my agenda. So first I will introduce you briefly into what is pediatric MDS. Then I will spend a few slides on GATA2 deficiency. It's a highly penetrant MDS predisposition syndrome. And then I will talk about some D9NL syndromes and try to pitch to you the idea on CHIPI. So I would like to start with a brief intro into the characteristics of pediatric MDS. First, MDS in children is a rare disease accounting for below or equal 5% of pediatric heme malignancies. Most kids have hypocellular marrow, unlike adult MDS. Regarding karyotypes, monosomy 7 is most common aberration, along with somatic mutations in genes like ZBP1, AS601, RUNX1, and the RAS genes. We do not find adult type alterations like del5q, RARS, and typical adult type mutations. And we know that germline predisposition is a hallmark of disease in children. Right now, we estimate that roughly 20% have germline mutations, but there will be certainly more to be discovered in the future. And finally, our therapeutic approach in pediatric MDS is always curative, which means hematopoietic stem cell transplantation, often without or only minimal cytoreduction. The classification of pediatric MDS is rather simple, and it is based on the blast count in the bone marrow. In blue, you see the ICC classification, and in red, the WHO classification. The majority of cases fall under the category of refractory cytopenia of childhood, or MDS with low blasts, as they have below 5% of blasts in the bone marrow. And about 1/3 of the patients have bone marrow blast count above 5%. Now, since many of the RCC patients are quite hypocellular, there is obviously a diagnostic overlap with severe aplastic anemia, similar to many of you experience in adult hematology with aplastic anemia and hypocellular MDS. So it is important to have this distinction because in children, we do not see germline predisposition in aplastic anemia, while we see germline predisposition in patients with refractory cytopenia. And here you see the major MDS-AML predisposition syndromes in relation to the age of onset and the type of associated heme malignancy. These syndromes can present with MDS-AML often without pre-existing features, unlike the secondary MDS that follows the inherited bone marrow failure syndromes. And these are single gene entities, mostly with autosomal dominant inheritance. On the bottom, you see the conditions which primarily manifest during childhood and young adulthood. And on the top are the syndromes most of you are very familiar with, like anchoring D26 and DDX41. And one challenging aspect is often the variable penetrance. And most challenging is actually the genetic divergence, meaning one gene causing many different, often unique phenotypes. And this genetic divergence I would like to exemplify with this case. This is a 16-year-old female, previously healthy, presented with refractory cytopenia, had trisomy 8 but no somatic mutations. Then over time, she lost her trisomy 8 clone and her counts remained stable. But when she was 31 years old, she developed AML with trisomy 8 and NPM1 mutation. At the same time, her 5-year-old daughter, who had congenital deafness, develops MDS-EB with mono7 and AS601 mutation. Okay, so what do you think is the most likely disease driver here, germline disease driver? That's correct, it's GATA2 deficiency. So this is GATA2 deficiency, which is highly penetrant, has variable manifestations which are always progressive, and is caused by germline heterozygous GATA2 mutations. There is a good body of literature showing the progressive nature of GATA2 deficiency. On the left, you see a study from the NIH showing that by the age of 40, most patients have developed symptoms, which is on the top left. Up to 60% have developed MDS in the middle, and on the bottom is the transplant-free survival, which also gets worse with age. Looking at infections, which is depicted on the right, by age 40, half of patients have mycobacterial or HPV infections, and almost 2/3 have bacterial infections. And those are pretty serious, leading to hospitalizations and even ICU stay. So in my previous institution in Freiburg, in Germany, we looked at the prevalence of GATA2 deficiency in consecutively diagnosed pediatric MDS. Those were 508 patients. And we found that GATA2 deficiency was accounting for 7% of all MDS patients, and for 15% when we looked only MDS with excess blasts. And of the GATA2 patients who developed MDS, 70% had monosomy 7. Now, next we asked how common is GATA2 in an unselected cohort of MDS with monosomy 7. And here you see that 37%, so basically 1/3 of monosomy 7 children have GATA2 deficiency. When we stratify by age, which is shown more on the right, the frequency dramatically increases in adolescents. So basically 72% of adolescents who present to your clinic with MDS monosomy 7 most likely have GATA2 deficiency. And similarly for trisomy 8 cases, on the bottom you see that 16% of MDS with trisomy 8 in children have GATA2 deficiency. So what about treatment? We know that GATA2 deficiency is always progressive, and the earlier you transplant, the better. This was nicely shown by our French colleagues who looked at the age at transplant versus outcome. That is shown here on the left. Donadieu published in Hematologica 2018. And they have shown that at age 18 to 35 years, the overall survival drops to around 60%. Then in patients older than 35, it is only 40%. However, this was a retrospective cohort of mostly pretty sick patients, and we believe that transplant outcomes now, when we look prospectively, even for adults, are much better because we know the disease better, so we can transplant them earlier. And as for disease-free survival in pediatric cohorts, you see that for normal karyotype and refractory cytopenia MDS subtype, the disease-free survival is 90%, so it's pretty good compared to the adult cohorts. When the patients develop monosomy 7, it is lower, so between 40 and 70%, depending on the MDS subtype. So what we can conclude here is that we should transplant early before patients develop severe immunodeficiency and monosomy 7, which is a high-risk clone. So when we put this all in context, based on the lessons we have learned in the past 10 years, GATA2 deficiency has a very high lifetime penetrance, above 80 to 90%. Patients can either develop MDS as children, or over time, the ones who don't develop MDS, they develop stem cell loss, which leads to severe immune cell deficiencies, severe infections. But most of these patients as adults then progress to actually adult onset heme malignancies. And when we counsel the patients, our patients on their risk profile based on their mutations, we always have to dig in literature, look into the appendices of the papers for mutations, for the genotype, phenotypes. So each time it was very time-consuming for us. So our idea was to create an online resource where we can easily access the information on genotypes and phenotypes of GATA2 deficiency. So if you have a question about a specific missense GATA2 mutation, I could tell you how many patients were presented with what type of phenotype. And this was inspired by our success of our SAMD99L mutation database, which is actually already online since multiple years. So here for GATA2 deficiency, we have almost 1,000 cases. Median age at diagnosis is 17 years. 60% have MDS, 65% have immunodeficiency. And we also have more granular details, for example, on the type of infections and also non-hematologic syndromic phenotypes, which we find in about half of the patients. So for example, you see here lymphedema or hydrocele present in 13% of patients. So if you have lymphedema, hydrocele in a patient with cytopenia, the probability is very high that it's GATA2 deficiency because we don't see it otherwise in other syndromes. And we will launch this in about 2 months. If you have questions or cases you want to contribute, please reach out to me. We discovered 3 major mutational subtypes: missense mutations in zinc finger 2 in about 45% of patients, null mutations in 44%, and other mutations including hypomorphic mutations in 11% of patients. And again, this is our beta version of the database. It's not online yet, but you can access all the phenotypes as shown in the table, and you also see the mutational distribution as shown by this lolly plot of mutations. Okay, now let me change the topic to SAMD99L syndromes. Many of you probably hear it for the first time, so I want to set the stage with a case presentation. Previously healthy 4-year-old patient had RSV infection and developed severe pancytopenia, had previously only mild developmental delay, but otherwise family history was normal. And our standard marrow failure diagnostic panel was normal, including telomere length, chromosomal breakage, PNH. The bone marrow was hypocellular, but there was some mild megakaryocyte dysplasia, so we couldn't really call it aplastic anemia, but it looked like this almost. And when you look here, the patient cleared the virus infection. When the patient cleared the virus infection, her CBC almost completely normalized. Her marrow improved the cellularity to 40%. But then a month later, she had another virus infection, which resulted again in pancytopenia. And the genetic workup identified a germline and a somatic SAMD9L mutation. And I will tell you more about how we can distinguish germline versus somatic in a moment. Now, SAMD9 and SAMD9L, which is the paralog of SAMD9L, likely evolved through evolutionary duplication. Both are located on chromosome 7q, and they are both interferon-responsive genes with antiviral function. So they basically restrict the interspecies viral infections. They negatively regulate the cell growth, and the SAMD9L germline mutations are gain of function. Their overexpression kills the cells, and any infection can actually potentially trigger this, because any infection would drive the interferon response, and the mutation would be highly expressed and would be killing the cell, intrinsically the cells even more. So what you see here is both the SAMD9, oh, you don't see it, I'm sorry, that's a conversion problem. But essentially the SAMD9 and SAMD9L genes have certain genotype-phenotype associations. This was compiled based on our online registry by Masanori Yoshida and Sushi Sahu. Masanori is a very talented postdoc in my lab. He's also a pediatric hematologist. And by the way, he's looking to come back to Japan next year. So SAMD9 is associated with Mirage syndrome, which is early onset, very severe manifestation with adrenal hypoplasia, genital phenotypes, growth failure, IUGR, and so on. So lots of different phenotypes. These children, the most severe ones, die as infants within few months. And on the other hand, the SAMD9L can present with autoinflammation, here called SAMD9L-associated inflammatory disease, SAID. Some of them, not all. And over time, when patients grow older, the only presenting sign can be ataxia or nystagmus. Now, this is actually of relevance to all the adult hematologists, oncologists here, because you might be asked by a neurologist for a consult, a patient with ataxia or with nystagmus has a cytopenia. I can tell you that is SAMD9L, because we had lots of these consults. So patients basically might even not have cytopenia, they just have neurological problems. That's what we see based on the family histories. But the most common denominator between these two genes is shown in the middle. That should be like a big gray circle, but it didn't work out from the conversion. But the most common denominator between both genes is cytopenia, B-cell lymphopenia, and pediatric onset bone marrow failure and MDS. And you know, unlike all the other germline predisposition where the risk increases with age for MDS and AML, SAMD9L is pretty unique because the risk decreases with age. So it's highest in young children, and the older the patients get, we don't really see an increased risk in adults. So it's only a few cases reported. So now we have around 300 cases in our database, and as you see here, the heterozygous mutations, mostly heterozygous mutations, are distributed between the middle region and C-terminus. This is the major mutational clusters. There are some hotspots like the amino acid arginine 986 in SAMD9L gene, where about 20% of the patients carry this mutation. And looking at the type of mutations, more than 90% are missense heterozygous. We have only few truncating in the SAMD9L gene. Okay, now the patient I presented before had also a somatic mutation. We believe these somatic mutations are compensatory, so they basically neutralize the germline deleterious or the germline toxicity of the germline mutation. And in this very simple growth assay, we overexpressed several mutations from SAMD9 patient in HEC293 cells. On the y-axis, you see the cell number after 2 weeks of cell growth. And in blue is the empty vector, in red is the Y-type SAMD9, and the germline mutations are in gray. Then when we move to the right, the somatic SAMD9 mutations are in black color. And then on the right, we have in the green color both the germline and somatic mutations co-expressed together, how they appear in patients. So the interesting feature here is that all the germline mutations severely inhibit the cell growth, as we would expect. But what was unexpected is that somatic mutations alone can also inhibit the cell growth, But when we co-express them with Germline, as you see in green, they improve the growth. So there must be some compensatory mutation in the protein. We don't know the protein very well. It has not been crystallized. We don't know much about the function yet. So this is a prototypic genetic rescue mechanism where a somatic mutation compensates. And before I continue with the somatic rescue in SAMD9, I would like to briefly introduce to you the concept of clonal hematopoiesis in predisposed individuals. I would like to pitch to you that concept. So in regular CHIP, we do see clearly a positive selection in the Darwinian sense. Something that is gained improves the fitness. But many of these clones are maladaptive and premalignant. Now, on the other hand, in germline predisposition syndromes, in bone marrow failure syndromes, where the germline mutation causes an intrinsic defect, we often observe negative selection. So it's something where, through somatic gene rescue, the germline mutation is inactivated. We select against that one. And in the bigger context of CHIPI, such negative selection is common in germline predisposing syndromes, also in bone marrow failure, as is shown in the slide from our recent review on CHIPI in seminars of hematology. Now, let me go back to the SAMD9-9L case. Because the germline mutations are very hematotoxic, various rescue clones develop in the patient's marrows. So the easiest kind of way to lose the germline mutation on chromosome 7 is to lose the whole chromosome 7. It's always non-random. We always lose the germline mutated chromosome 7. Then the second type of somatic rescue is an incis compensatory SAMD9L mutation, which is somatic. And the third one is uniparental disomy. And that's an interesting concept because uniparental disomy is quite common in interchromosomal exchanges are quite common during meiosis, but in the mitotic setting, it's quite rare. So this is how somehow they are enforced. You have crossover between chromosomes, and the Y type is duplicated on the chromosome 7q. We can detect it using the first one using metaphase karyotyping, the second one using NGS panel, and for the third one we need SNP array. Of course, we cannot detect it using CGH array because we need the allelic, the heterozygosity versus homozygosity of the alleles. And finally, the clinical effect, the first one is premalignant at first, so actually many of them for the monosomy 7 is benign. I will explain it in a second. The bottom two are adaptive clonal hematopoiesis. They have rescue potential, both biological when we do grow them in culture and also clinical. And for our study, we also wanted to answer if these clones are arising independently or together. Let me fast forward. So we established a single-cell DNA-seq assay that can detect chromosome 7 changes and mutations. This is one exemplary patient where a germline SAMD9L mutation was found. In 1,600 cells, we were able to genotype those cells, and 27% of them represent the native germline hematopoiesis on the left. 25% are with somatic rescue clone in blue. Then in 8% we see UPD7Q, a rescue clone. And finally, we see two monosomy 7 clones, one without and one with EZH2 leukemia driver mutation. So in conclusion, this patient, like many others, have multiple clones which are functionally redundant. And I'm quite enthusiastic about this method because we also compared bone marrow and peripheral blood in many patients from the same time point, just mononuclear cells. As shown here, we are able to detect both the somatic events, like SAMD9-9L and UPD7Q, but also the karyotype changes in peripheral blood. For example, monosomy 7, here at 3% in peripheral blood and at 10% in the bone marrow. So especially in small children where we want to avoid repeat bone marrows, this might be an option in the future. Now, towards the end, I want to show you a few examples of clonal competition or war of clones of SAMD9-9L syndromes. This patient had monosomy 7 at the age 2 years old. As you see by the orange cells in the middle, it's in 77% of the cells. Chromosome 7 with the mutation is lost. The family was lost to follow-up, and at age 6, they reappeared. Monosomy 7 has disappeared. And the patient had a large UPD7Q, which replaced the germline mutation with the Y-type allele. We quantified, and we saw that 60% of hematopoiesis came basically from one single hematopoietic stem cell. And the patient is now over 30 years old in remission and still has normal blood counts and no high-risk clonal hematopoiesis. This is another child with germline SAMD9L mutation who had 4 types of cells, cell types identified on single-cell DNA-seq. The green clone, the gray one is the germline hematopoiesis. In blue, you see the somatic SAMD9L mutated clone. Then in green is the UPD7Q rescue. And in red, the monosomy 7. Now, over several years, the monosomy 7 clone disappeared, the UPD7 clone remained stable, and the somatic clone took over. So again, 73% of hematopoiesis comes from one reverted hematopoietic stem cell. And finally, in this patient, the monosomy 7 clone outcompeted the native hematopoiesis and the UPD rescue and expanded. Patient had progressive cytopenia and required stem cell transplant. So here you see the transplant outcomes in pediatric MDS according to genetic subgroup, the Germline genetic subgroup. In gray is the wild-type pediatric MDS, where we don't know if there is any germline predisposition. We haven't identified it yet. In blue is the SAMD9L cases, and in orange, the GATA2 cases. On the left are patients with the normal karyotype, and on the right with monosomy 7. And what becomes clear is that the overall survival with normal karyotype is excellent across all the groups, so there is no difference, around 90%, while it is much poorer in patients with monosomy 7, so that drops to like around 70 to 80%. But this was our retrospective analysis before we knew that these patients with SAMD9L had, there was even this gene in existence. So now the question is, knowing that some patients with SAMD9L can actually undergo spontaneous remission, are we unnecessarily exposing these kids to myeloablative conditioning and potentially toxicity and TRM? So at St. Jude, we started a prospective surveillance cohort where we follow SAMD9L patients who are stable. Of the 23 cases, 12 had monosomy 7. So we don't transplant them, we just follow if they're stable. Median age at diagnosis was 1 year, and follow-up right now 1.2 years, from 0.1 to 4.4 years. The outcome is that 2 out of these 23 cases had to be transplanted due to progressive cytopenia. Both of these patients had monosomy 7, but the most striking is actually for us is that none of the patients who had monosomy 7 developed advanced MDS-AML or leukemia driver mutations. And Nathan Gray, who is here from St. Jude, he is the first author on that paper and poster. He can explain to you more at his poster at the meeting. So in summary, GATA2 deficiency is accounting for 7% of pediatric MDS, always progressive, severe immunodeficiency, high risk of advanced MDS, always needs a transplant if they progress. SAMD9L syndrome account for 8% of pediatric MDS. Over 2/3 of the patients have somatic rescue events, and the overall survival in pediatric MDS is similar across genetic subgroups. But GATA2 patients always need transplant when they develop monosomy 7, whereas SAMD9L patients, if they have monosomy 7 and are stable, they can be followed. So typically we do that in preschool children. So there is a rationale for monitoring SAMD9L patients without transplant. And I would like to thank my lab and the European Working Group collaborators and also the Northern Aplastic Anemia Consortium. You can access our mutational database through this link. Thank you very much.
Thank you very much. Please.
So, thank you, Marcin. Fantastic talk. Very, very informative. So I'd just like to comment that the GATA2s, I mean, we who see an adult MDS population, we see not few GATA2 germlines that sort of appear with MDS or AML at higher age. Is that also your impression? Have been paddling around as children and teenagers, very often with the marked warts, and then suddenly they get MDS features, but they may be 25, some even older. Do you think, is that common? What is the incidence in your hands?
Well, I think that the patients who do, so there is only one genetic subgroup in GATA2. Those are the intron 5 mutations. They have incomplete penetrance. I have seen adults who are really asymptomatic. They might have some B-cell cytopenia, or when you look into the marrow, slight dysplasia, but nothing else. But all the other ones, I think the penetrance for immunodeficiency and then progressing to MDS-AML, I would say it's like nearly full, nearly 100% over time. No. So we sometimes see these like 60 years old who suddenly develop MDS, and before they had these cytopenias. And you also have to acknowledge that the problem with HPV and HPV-related cancers, right? That's also one problem we have, and if you do transplant, you cure them from that as well.
Yeah, no, I do agree. I'm just saying that just because you're an adult hematologist, you can't rule out GATA2 germline mutations.
Thank you.
So great talk again. So my question is that so about the 79L. So these are of course a German variant, and so some German 79 is so the causative of the Miller syndrome. So my question is, there's any what is the constitutive symptoms and signs and symptoms outside of the hematologic system? It depends on the mutation pattern, type of mutation, and this one first question.
Yeah, excellent question. I think it's for 79L gene, we see that about 50 to 60% of them develop neurological problems, ataxia, spinocerebellar ataxia, and nystagmus over time. This can lead even to situations where they cannot walk. They need a cane or they sit on a wheelchair. That's for 79L. For 79 gene, we rather see either the very early onset, most children die as infants from multi-system disease, or the ones who are milder kind of, but we don't understand yet which mutation. There are certain mutations who are always infant kind of early mortality, but certain mutations where they are ambiguous, right? They can go both ways. So we are learning that from our mutational registry to kind of get this genotype-phenotype correlations.
Mm-hmm. So the second question is, have you ever checked the how many clones are positively selected, somatic clones are positively selected for the 79 cases by ultra-deep sequence, highly sensitive?
That's actually a project we are doing now where we want to compare the fibroblasts to the hematopoiesis to increase the accuracy. So right now when we have a threshold of 1%, we see sometimes 7 to 9 clones per patient. But I suspect there will be hundreds when we go really deep, right?
Okay, thank you.
Yeah, thank you.
Please, last question.
Dr. Manabe from Japan. Sorry. Thank you, Martin. Always beautiful talk. And I have a question about the rescue. So in 79L, rescue works maybe because of 79 is located on chromosome 7 or so. Then for GATA2, no rescue works. Then, but some patients, for example, with Fanconi anemia or so, some kind of rescue works. So in which case rescue works, or in other words, why rescue doesn't work for GATA2?
I think maybe when we go deeper in 79L, I can tell you I haven't shown that yet, but for majority of patients who have the rescue clones, they don't have clinical remission. And we combined a single cell with antibodies. We saw that the rescue is in lymphocytes, like T cells or B cells. And this is pretty common in immunodeficiencies, where like with Scott Aldrich and SCIDs, where you have the rescue in lymphocytes, it improves the lymphocyte fitness, but it doesn't repopulate the marrow. And in GATA2 deficiency, I think it's basically non-existent. There was only one patient reported from Brazil who had a BAC mutation in the hematopoiesis, and the phenotype improved. But it's not present in GATA2 somehow. We don't know why.
Okay.
Thank you.
Thank you very much for wonderful talk. And so let's move on to the last speaker. The last speaker is Hideki Muramatsu from Nagoya University, and he will talk about JMML.
Oh, I'm Hideki Muramatsu from Nagoya University, Japan. And thank you, Professor Takita, for kind introduction. And thank you for Professor Ogawa and Miyazaki for the invitation to this great symposium. I'd like to start my talk about JMML, juvenile myelomonocytic leukemia. Nothing to disclose. This is my cat. JMML is a distinctive subtype of MDS-MPN, and this is really, really very rare, about 1 to 2% of pediatric leukemia. And only 10 to 15 cases are diagnosed in a year in whole Japan. And JMML is characterized by several features, for example, hyperproliferation of myelomonocytic cells like this, and young children, mainly under 5 years old, and hypersensitivity to GM-CSF assays. This is figure from the Niemeyer's review, landmark discovery in JMML. The initial case was reported in 1924, and first 1991 NRAS and KRAS were identified, and 1994 NF1 mutation was identified, and then 2003 somatic PTP11 was discovered. And 2010 SIBO was identified as the 5th gene of JMML, and more recently genetic landscape was revealed by the whole exome sequencing analysis, and methylation classification was developed in around 2017. I'd like to introduce our works and so on. This slide showed RAS map kinase genes mutation in JMML, PTP11 and SIBO and NRAS, KRAS, or NF1 mutated. And very similar proportions were found in EWOG European cohort and Japan's our cohort. PTP11 is the most frequent, and then the KRAS, NRAS, and SIBO, and NF1. And very minor cases, all 5th gene negative cases. I'd like to start about talking about NF1 JMML. Most of NF1 JMML have clinical manifestations of neurofibromatosis type 1, clinical NF1, but some of them lacking the featured clinical NF1, but they have a mutation in NF1. And so typically, germline NF1 mutation plus the allelic different allele and occurred somatic events. This means somatic mutation or UPD or microdeletion. And NF1 and JMML is usually showed poor prognosis. And a SIBO JMML is showed Noonan syndrome-like clinical phenotype usually. That's we call SIBO syndrome. And typically, one germline SIBO mutation plus somatic events. This means somatic mutation or UPD11Q or microdeletion. And SIBO JMML showed relatively good prognosis. This Kaplan-Meier is our Japanese cohort data. SIBO showed the best prognosis, and then negative cases or NRAS KRAS. And then PTP11 or NF1 showed poor prognosis. Why? Secondary genetic events were revealed by the whole exome sequence analysis in 2013 and 2015 from French and USA. This figure came from our Japanese cohort. As you show, PTP11 and NF1 and the NRAS, KRAS, and SIBO are basically mutually exclusive. And PTP11 or NF1 cases have the significant proportion, high proportion of presence of secondary genetic events, in this case, ZBP1 or JAK3 mainly. And patients with secondary genetic mutation showed poor outcomes. So this is one of the reasons why the PTP11 or NF1 showed poor prognosis. More recently, we performed the mutation analysis. In addition to the mutation analysis, we performed the RNA sequencing and genome-wide methylation data analysis. In this study, we found activated tyrosine kinase inhibitor fusions, and tyrosine kinase infusion were identified. 3 cases we identified, 2 cases with ALK fusion and 1 with ROS1 fusion. And we successfully treated with crizotinib, this made ALK inhibitor. And this case was totally not responded to the usual chemotherapy, and with monosomy 7 and showed the increase of blood cells, but only 30 days crizotinib treatment, she got molecular remission and bridged to the matched sibling donor transplant and survived more than 5 years. In this paper, we also analyzed genome-wide methylation analysis. And 450K methylation array, we can divide it, the JMML cohort to 2 parts. One is the hypermethylation profile, and the other is with hypomethylation or low methylation profiles. And this methylation profiles is a strong risk factor for in JMML cohort. Patients with high methylation profile showed poor prognosis, and this and similar study at the same time published from the United States, and this is from Germany. Of course, all of us had the same idea, so use the same 450K array. So we propose international collaboration study. So we published international consensus definition of DNA methylation subgroup in JMML with around 300 JMML cohorts. So in Europe and America, United States divided the patients of JMML to 3 groups. But in Japanese analysis showed the 2 groups. Why? We discussed with why are we at 2 and the European and the United States 3. The answer is this is a European study, and this is Japanese cohort, this is United States cohort. European and United States show that each about 30% of cases are classified as LM or IM intermediate or high methylation. But I don't know why, but the proportion of the intermediate methylation patients is very low in Japan, so only Japanese cohort divided to 2 groups is, it's reasonable. Anyway, now we divide the JMML to the low or intermediate or high methylation classification is our international consensus. So the next topic is hypermethylation. High methylation is significantly associated with the known risk factors of JMML. For example, exclusive to SIBO mutation, and association with NF1 or somatic PTP11 or presence of secondary genetic events or high hemoglobin F level or higher age or LIN28B overexpression or expression profiling like ML. So my question is, can I predict methylation status only by clinical parameters? This is a collaborative study with UCSF, and we set a training cohort and a validation cohort. And adjusted logistic regression to predict 450K based methylation status in training database. Of course, age, hemoglobin F plate, and the monosomy 7, and the last pathway gene mutations are significantly associated with methylation status. And we performed machine learning algorithms, and we ran 3 hypothesis decision tree, one support vector machine, one naive-based model. And we decided to use the decision tree algorithm. The answer is very simple and easy to understand. If the PTP mutation was positive, then hyper or intermediate. And if no, if patient have hemoglobin elevation, if no, low methylation. And if yes, if age over 2 years, and this means hyper, and if no, low methylation. And based on this algorithm, this is a training cohort, and this is a validation cohort, but we successfully show the association with survival outcomes. So I'd like to move on to the treatment part. And as I show, the methylation is important molecular mechanism of JMM pathogenesis. And of course, so the hypomethylating agent will be a good candidate for treat JMML. The first case report of JMML showing clinical response with azacitidine was in 2009 from Germany. And they treated with 1 KRAS and monosomy 7 JMML case treated with azacitidine. And after 5 courses, the patient showed cytogenetic response. And after 7 courses, molecular remission was achieved. So they performed a retrospective analysis of 12 cases and evaluable 8 cases. Among them, 5 showed clinical partial response, and molecular complete remission was achieved in 2 of them. Recently, they published a prospective assessment study for JMML, but they exclude SIBO cases because the SIBO showed good prognosis. And, but unfortunately, high methylation profile patients showed poor response. Only 4 of 11 showed response, but low and intermediate showed a 100% response rate. Surprisingly, overall survival and leukemia-free survival in total cohort was exceptionally high because historical JMML cohorts showed the survival rate about 60 to 70%. I'd like to move again to SIBO JMML. In Japanese cohort, SIBO accumulating the patient number, so we reassess the survival outcomes. But unfortunately, the survival outcome is not so good as previously shown. Overall survival is about 70%. What happened? So some cases progressed, and I performed a literature review and reported in outside Japan. In Japan, Japanese cohorts comprised 22 cases, and the literature review cohort was 65%. In Japanese cohort, 6 of them dead. In literature cohort, showed 10 cases progressed and died of disease. So this means SIBO is not always benign. This is a summary of Japanese cohort and literature review. Some of them received SCT, and some of them relapsed, and some of them died of the disease. And the methylation profile is usually low methylation. So of the 50 patients with evaluable methylation data, 22 of Japanese and 28 literature review, 49, most of them were classified in the low methylation subgroup, and only one was in the intermediate methylation subgroup, suggesting that DNA methylation profiling is not a sufficient SIBO mutated JMML classifier. So patients with SIBO JMML represent a heterogeneous population, including cases that require therapeutic interventions, such as hematopoietic stem cell transplantation. Now, in Japan, we perform ongoing Japanese prospective other study. In this study, based on this finding, we include SIBO. And very simple clinical study, only treated with azacitidine or more than 3 cycles and bridge to stem cell transplantation. If the patient with SIBO, we observed only azacitidine. And now the 22 cases are registered, and we will evaluate the response using the consensus criteria for JMML. And luckily, our case, nobody died in these 22 cases. I'd like to show our recent publication about our previous prospective study for JMML and JMML11. This is a stem cell transplantation study using the busulfan, fludarabine, and melphalan conditioning regimen. This is total features. Registration 31, eligible in 28. Engraftments were achieved in 21, graft failure 6, and early death 1. And about engraftment cases, 18 are survived. And using a statistical analysis, that white blood cell count at stem cell transplantation is a strong risk factor. I think this is associated with tumor burden. And if the patient white blood cell count more than 7,000, significantly higher relapse rate. And in this study, showed the smaller children, this means body surface area, and 0.5 square meter, showed higher transplant-related mortality. So this is our future perspective. Based on JMML11 study, showed the tumor burden associated, of course, to relapse. Small body size associated TLM, especially associated with TMA or SOS VOD. So our idea will be reducing busulfan dose for patients with smaller BSA, or RIC regimen we'd like to try with patients if they got low tumor burden, for example, with Zashi. So we need a new method for the MRD measurement in JMML also. In 2021, we published a leukemia about the ddPCR method to check the MRD analysis. This is using a SET-BP1, JAK3. These are secondary genetic events, but very minor secondary genetic events associated with poor outcomes. So we broadened this idea using the error-corrected next-generation sequence analysis. And we performed around 100 cases with 21 gene panel of the error-corrected sequencing. And this is an overview of identified mutations. Measured, this means more than 5% clone, VAF clone, about 81%, but some of them, about 20 cases, have the minor clone. This means under 5% variant frequencies. And we confirmed a good correlation with the ddPCR and this error-corrected sequencing with the SET-BP1 and JAK3 mutations. And this is a clinical feature of this summary. About 23 has secondary mutations above, and of course, some of them have more than 2 mutations in RAS pathway genes. And we confirmed the minor under 5% above is associated with clinical outcomes. And surprisingly, the RAS-W mutation is a stronger effect than other additional mutations. And actually, honestly, this is recapitulate data of the French cohort in 2015. They also show that RAS-W mutation is significantly lower overall survival. So this is my last slide, and thanks for everyone for contribute our work about JMML. And thank you for your attention.
Thank you very much for your nice talk. And any other question or comment?
Go ahead.
Atsushi Nobe from Sapporo. Thank you very much for your comprehensive and very nice talk. But I have one different question, but I'm sorry. But so in principle, JMM cells use RAS pathways, of course. So why you don't try inhibition of RAS pathway like MEK inhibitor? Please tell me something.
Yeah, of course I want to try. And UCSF, United States team by the Stiglitz tried methylation MEK inhibitor, and they published in last ASH meeting and showed the clinical benefit. But unfortunately, they did not receive got the molecular remission, but they ameliorate clinical phenotype. So of course, MEK inhibitor could be a good candidate, especially combined with azacitidine. Thank you.
Yeah, please do that.
Hi, I'm Marcin Wlodarski from the University of Tokyo. Thank you for your excellent talk as usual. So, when focusing on CBL JMML, so could you provide some comment or information about extra non-hematological event of CBL leukemia, CBL JMML, such as especially I'm interested in cardiovascular event of the CBL patient.
Yeah, thank you for your comment. We have several, 2 or 3 cases of moya disease, and of course reported cases with Takayasu arthritis. So, and very interestingly, some of them ameliorate after stem cell transplantation. So the SCT could be a good treatment for the such extra hematological complications in severe cases. Thank you for your comment.
This vascular complication is limited to CBL patients?
Yeah, basically. Yeah.
Thank you.
So, okay. So thank you very much all for your invaluable contribution and insightful discussion. I will close this session by thanking all the speakers and audience. Thank you very much. Thank you very much.